We've used CancerTYPE ID in our clinical practice in a number of situations. When we get a pathology report back, the first thing we do is look to see how they document where the tumor that they're describing appears to have originated from. And there's often a long description of immunohistochemical stains describing what they conclude. Today, the pathologists are relying more and more on outside interpretations, especially molecular markers and certain specialty pathologists, so that the reports we sometimes get back are inconclusive, or they're ambiguous from a histologic and immunohistochemical standpoint, specifically if we're confronted with a carcinoma of unknown primary site, or potentially one of those ambiguous states, an example of which might be metastatic squamous cell carcinoma in the lung that could theoretically be a primary bronchogenic squamous cell carcinoma metastatic to the lung, or could theoretically be a primary site in the head and neck. An example might be a patient with a non-small cell lung cancer who is TTF1 negative, where most lung cancers, but not all lung cancers, are TTF1 positive. So we're faced with a pathology report now and a pathologist who tells us we think this is lung cancer, we think this is non-small cell lung cancer, but we can't be absolutely certain. That would be a reason to use the CancerTYPE ID. And then obviously if the presentation is abnormal, or it's a solitary or multiple metastatic site at some distant point from any organ, then CancerTYPE ID is very helpful in these situations.